Iron deficiency anemia is perhaps the commonest type of anemia we encounter. What are the features of iron deficiency anemia? There are general features like every other anemia. It generally produces a chronic anemia and is tolerated for a very long time until conditions like infection, bleeding, or pregnancy precipitate symptoms, or if the patient has developed cardiovascular compromise. Then patient may develop symptoms like weakness, fatigue, shortness of breath, dizziness, lightheadedness, burning sensation in the oral cavity, in the tongue, thirst, angina with normal coronaries. Even in very rare cases, when the hemoglobin is very low, patient may develop confusion as well. When you examine, you may see a generalized pallor, koilonychia, or the brittle nails are specific features of iron deficiency anemia. There may be red, sore tongue, there may be tachycardia, the pulses are generally good volume, it may be regular or it may be irregular, patient may have hair loss, there may be dermatitis herpetiformis, which is indicative of wheat allergy or gluten allergy. Then some of the patient may have splenomegaly, and in advanced cases, some of the patients may also develop the features of heart failure. When you see a patient with iron deficiency anemia, look for the risk factors for iron deficiency. For example, patient may have nutritional deficiency, the diet may not be adequate. Dysphagia, patient may have dysphagia because of malignancies like CA of the esophagus causing slow leaking of blood and compromising the nutritional intake as well. And then there is a condition called Plummer-Vinson syndrome when there is dysphagia and there is iron deficiency anemia. Dyspeptic symptoms may have underlying reflux disease, gastric ulcer, or duodenal ulcer as the cause of dyspepsia. Then drugs which can disrupt the gastric mucous membranes like non-steroidal anti-inflammatory drugs, and especially if combined with corticosteroids, that can be disaster. Then diarrhea with bleeding in inflammatory bowel disease, diarrhea without bleeding may be seen in malabsorption states like celiac disease. Then you got hematuria, chronic hemoptysis, menstrual disorders, that is polymenorrhea and menorrhagia, bleeding hemorrhoids, recurrent pregnancies and breastfeeding without supplementation, skin rash of dermatitis herpetiformis, exposure to hookworms and living in an environment where there are chances of having more hookworm infestation. Weight loss may be indicative of CA stomach or colonic CA. Patient may be having pica. Some of the patients having pica, they may be having iron deficiency as well. So look for the presence of these risk factors for iron deficiency. Then get CBC with peripheral film examination. The peripheral film is a very good examination which can tell you that there are microcytes, there are hypochromic, there is anisocytosis, there is poikilocytosis. Serum ferritin is a very good indicator of iron reserves, but problem is serum ferritin may be falsely high in patients who got inflammatory conditions because this is an acute inflammatory reactant. And then you can get serum iron and TIBC, from which you can calculate transferrin saturation. Transferrin saturation is a very good indicator of iron status, and a low transferrin saturation virtually indicates that patient has iron deficiency. Then bone marrow assessment may be required in some patients. Staining with Prussian blue is for bone marrow. The Prussian blue stain specifically stains the iron, and it's usually done in complex type of anemias. For example, if the patient has chronic renal failure and we are not sure because of the disturbances in the proteins, we may not be able to calculate the transferrin saturation. In those patients, we may require bone marrow assessment, but generally the peripheral parameters are enough to make a diagnosis of iron deficiency. Then go for celiac screening, stool for occult blood, stool for ova of hookworms, or there is DNA of hookworm. And then finally, you can go for GI endoscopies, the upper endoscopy, the lower endoscopy. Small gut can be seen with the enteroscope, or some with time with the capsule endoscopy. Start the patient on nutritional counseling. The diet should be advised appropriately. Oral supplementation of iron is the best way, but if the patient cannot tolerate oral iron, intravenous iron can also be used, or sometimes intramuscular, but intramuscular preparations are generally not available now. It is the intravenous preparation that can be used, and the disease which is actually causing iron deficiency should be treated. For example, if this is bleeding hemorrhoid or polymenorrhea, menorrhagia, or if there is hookworms, so whatever is the cause of iron deficiency, that should also be addressed.